Hi, everyone. So we just wanted to give a little summary about the two main tables that we're asking you to complete. One, which is going to be level of certainty, and that's based on the evidence. And then one that is going to be based on your clinical recommendations. So we understand that some of this can be confusing, so we wanted to just show you real quick what we're talking about. So I'll just go to the top here and just say, here's the table that I filled out, and I'll show you that afterwards. What we're looking at here is level of certainty for each of the drug classes of medication based on the disease state. So what we want to review with you what levels of certainty mean. So a lot of times we talk about grade, we say A, B, C, I. It gets slightly confusing, but what we want to really focus on is that we are dividing the evidence by high level of certainty, moderate level of certainty, low level of certainty, and then no, there's absolutely nothing published is really insufficient evidence or no evidence. So the way that we're going to ask you to do this is to read very closely what this means. High is pretty easy. It's also qualified by this term 1A. But for the purposes of you, we would like you to, if there is high evidence, to simply write high. Moderate, however, has two different subcategories. So moderate refers to there is available evidence that's sufficient to determine the effects of the topical analgesic on health outcomes. However, we know that for B, there may be well-designed, controlled, but there may be non-randomized clinical trials. So we may see some very large observational studies that, however, are not necessarily placebo-controlled. So that would fall into this moderate 1B. 1C would be something more like a retrospective or cohort or large case studies. So as you are rating the level of certainty for the different drug classes for each disease state, keep in mind that there's high, moderate, B, or C, and then there's low. So I want to show you my table here. So what I did is I looked at, so we divided them into FDA approved categories, not FDA approved for this clinical use, but clinically commercially manufactured, or not FDA approved, not commercially manufactured. Here are the disease states, and then here are the different drug categories. So for each one, I wrote high, and for moderate, I qualified with B or C for those disease states based on the evidence. What I also want to make sure you use, and then if I left it blank, that means there's insufficient or there's absolutely no data. So that's what we're asking you to do. And I also want to turn you to, I'm going to stop sharing screen here for 1 second, how I based my ratings and, pardon me. So I based my ratings essentially on the manuscript draft, as well as I used table 3. And table 3 is very long and large, but it is divided by each disease state. And table 3, which I'm hoping to pull up for you right now, really shows us what the individual studies were that we based our draft document on. So table 3 is what you should be referencing as you are doing this grading, in addition to what's written in the text of the draft. So I'm going to pull this table 3 up for us. And we can see, if I make this larger for us here, is that these are divided by drug state, and you can access a lot of the different studies listed, as well as how many patients were in the study and what the dose was, what their endpoints were, as well as the outcomes and the significance. So as you're going through all this and rating, you want to make sure to be using this table as the reference in addition to the draft. Erin, do you have anything to add to that?
Not to that. No, that was perfect.
All right, so that's task number 1. We want all of you that have done this, if this sounds totally weird and out of, left field, and this is not how you did it, then you need to go back and resend us your votes. Erin is going to then collate them and add them together and be able to report on our level of consensus. For instance, high consensus, more than 80% of us felt a certain way, and versus those below. Again, remember that blank means that there is not going to be there's insufficient evidence. We just didn't want it to be so busy on the table. We're going to ask you to leave that blank for now. So now I'm going to turn over to Erin, who's going to talk to us about how to use the next set, which is going to come as a survey that you're going to fill out, and that's really about clinical recommendations. So the whole point of this is not to necessarily synthesize all the literature, but to give our clinical expertise recommendations that are also informed by the evidence. Take it away, Erin.
Okay. So the point of this whole, enterprise with this paper was ultimately to come up with our recommendations that could be used clinically. So once everyone has had a time to go through and rate all the evidence and review the evidence per category, our next step is then to apply that to what we recommend. So we're going to this time have some sort of survey monkey sent out that'll make it a little bit more concise. But what we're asking is for you to give us your thoughts on if you would recommend a specific drug for a specific disease. And so that would be more of a strong recommendation based on the evidence. And in general, as a group, on the earlier Zoom today, we agreed that probably things ranked high or at least moderate on the level of evidence would support recommending the drug. Versus would you consider the use in a patient based on more your clinical experience? There may be low evidence. There may even be no evidence. But is it something that you use in your clinical practice? Would you recommend it? And again, we may have some blank categories where you just don't feel comfortable commenting because there's just no evidence on it and you've never used it. And I just put in here on the table sort of how I would fill it out based on, my review of everything. So I believe this is going to come in a free text type style where you'll have per disease state, and then you'll have a separate list of all the medication categories that we reviewed, and you can just enter what you would use and how you would recommend it. And then we'll put all of that information and share it with you, everyone again, and we can decide if we need to meet to discuss on another Zoom if there's strong disagreements or any major inconsistencies. But that way we can have something that's nice and concise to share with people to use clinically. Is that
Excellent. I would add to that, it's kind of this is what I would use as someone who in primary care medicine, for instance, where a patient comes to me and they have a post-herpetic neuralgia and they don't know what, and the patient says, I would like to use a topical analgesic. So how do we help people to have that information of sort of from our expert panel, again, based on the literature as well as our clinical expertise? What would be the things that we recommend that they could suggest to their patients and or prescribe? So this is, I think, where the basis of how this document is going to be really practical, understanding that that value of this document is not only a review of the literature, but also really on what to do when my patient comes to my office. Great. So stay tuned. You're going to refill out, if you didn't, you're going to refill out the level of certainty of evidence table using the high, moderate, B or C, or low, or leave it blank if it's insufficient. And then stay tuned as you're going to get this document. That's going to be really the follow-up. We'll give you a list of all of the different classes of drugs that you're going to be choosing from, but we want you to sort of really just write out more qualitatively, and then we'll find a way to quantitatively express the level of consensus based on the percent of responses. Please reach out to us with any other questions. Erin, anything else?
No, thank you so much for all your work. We appreciate you.
Absolutely. Thanks to all of our experts. Bye.
Bye.